You're listening to the RN Mentor, a podcast designed to document and bring you the work and experience of some of the most influential nurses in our profession. We will be sitting down and having a discussion with the leaders of today's nursing world as they share their work, how they navigate their nursing path, and their views on the future of the profession. My name is Ali Tayeb. I am a registered nurse, United States Navy veteran, a Jonas Veterans Healthcare Scholar, and your host for the RN Mentor. Hello and welcome to another episode of the RN Mentor podcast. This is a special episode kicking off season 4 of the RN Mentor podcast. I am so excited and a little bit nervous to bring you my following guests for this episode. We have with us Valerie Davidson. She is the president of the Alaska Native Tribal Health Consortium, a statewide tribal health organization that serves all 229 tribes and all Alaska Native and American Indian people in Alaska. We have also Evelina Aki as a nurse manager with the State of Alaska Department of Health and Social Services, the Division of Public Health, and we have Lauren Carroll, and he is a public health nurse with the State of Alaska Department of Health and Social Services, Division of Public Health, and is a Johns Hopkins Bloomberg Fellow in the Master of Public Health program. I would like to first of all welcome you all to the show, and thank you for being here with us today. Before we get too much into the what we're going to be talking about, I just want to give the audience a little bit of heads up of why we're doing this. Really, it comes from my interests, and Lauren came to me a while back and said, "Hey, what do you think about doing this?" And it just happens to be in line with where I wanted to, or something that I was interested in, and I jumped on board and I said, "Yes, let's do this." And I really had an interest in the native populations of the U.S., and I am very much interested in rural health and how everything happens in rural America, and how do we get the services that the various populations need to them, because the expectation of everybody is going to be going to the big cities for their healthcare system, for their healthcare or anything like that is sort of not realistic. So want to really explore. Alaska seems to be it's such a huge state and the population a bit scattered, so I thought it would be an excellent way to introduce everybody into the Alaskan health system. So I'm going to kick this off with actually Lauren. Like I said, we talked a while back and wanted to what is the Alaska public health system look like, especially since we've had this year plus in the COVID world. So I know it's been a huge public health factor. If you can talk to us a little bit about that.
Oh yeah, sure thing. I guess first I would say thanks, Ali, for inviting me and for inviting us, and thanks for Val and Evie for cutting out time out of your day and week and month to kind of come together. And that's also kind of in my mind reflective of our public health system in Alaska. So when I think about public health and what is that in Alaska, it's in my mind, it really is and always has been a team effort. So in regards to this section of public health nursing, that's the state government organization that Evie and I are employed by. We have 16 public health centers statewide, and we got about 158 permanent positions. So we do have a pretty steep vacancy rate right now. And we also have built a supplemental workforce to help us through COVID. And so that's about an extra 450 or 500 short-term employees and private contractors that we've had for about the past year.
Now in the Alaskan public health system, especially from a nursing perspective, how connected are you? Because with 150 plus in the system. And Alaska, again, in my head, when you look at a world map, Alaska doesn't look that big, but when you take Alaska and you put it on the US map, it's like it's probably the size of at least a third of the US or something like that, the way it looks like, right? So it's a pretty huge state. So how stretched thin are you when you're saying when you need to do a public health rollout? What does that look like?
Oh boy, that's a good question. Evie and Valerie hop in here. I
Yeah,
know you
please.
got a lot to add, but when thinking about the state of Alaska, we're actually, like you had kind of said a few minutes ago privately, we're pretty small in regards to population. We're about 700 people, but Texas is a pretty big state, but Alaska roughly about 3 times bigger. So we got about 660,000 acres, pardon me, square miles. So that's about 0.8 square miles per person. So we have a lot of room. And so what that means for population focused healthcare folks like public health nurses, it means that most of our work is based on relationships. And so we've been around since 1893 in some form or other. So we're celebrating 128 years of public health nursing in the state of Alaska. But the interesting thing there is we've been partnering the whole time with Alaska Native villages, community members, but also organizations like Alaska Native Tribal Health Consortium.
Thank you. Now, Evie, I'm going to throw this your way. I mean, from a you being in a nurse manager role, what does it look like for you to coordinate efforts, not only with among the people that reports to you, but trying to coordinate efforts along the state, or however you guys coordinate like bigger things, like again going back to COVID has been really, like when it started, the federal government kind of pushed it back onto the states and said, hey, you guys need to take care of this. What did that coordination look like from a state level for a state like Alaska?
So in this area in Southwest Alaska, part of Bethel area, there's like 56 villages around, and Bethel is the hub of the villages. But we collaborate with everyone, like all the village clinics, and then with COVID, we collaborated with YKHC, and then the state epidemiology and other clinics throughout the state. And what we did was like everything was on through the computer, like where we had to call like telecommuting. And I think that was an eye-opener, especially for the public health center in Bethel deals with a lot of TB. I mean, TB is still here. So our main focus was TB for the public health center here. And then we're very lucky that we have an agency like YKHC that helped us with the COVID contact investigations and giving the vaccines, because they have more staff and we don't, or I guess everyone has low staff, even they have low staff, but they have been such a tremendous help to us, and it kind of forced us to help each other out, especially with COVID.
Yeah.
And then now we can use the COVID, what is that? The contact tracing and everything that we used, with maybe trying to integrate TB with that.
So trying to did you guys have to create new tools for COVID, or just something like that was made available to you guys?
Yeah, so there's contact investigations are done on through ComCare, and then I know that YKHC had their own contact investigations other than what the state uses. So it's their own agency, I guess, depending on what they want to use.
Right. So it sounds like, it helped build some sort of team
Yeah.
coordinations and communications. Some of those actually were people were forced to communicate with each other now you mentioned the low staffing. What is and anybody can jump into this one. What are the issues with those vacancies, that the shortfalls in healthcare providers or healthcare workers? Sounds like I know a lot of states kind of suffer from this, but what do you think the reason is that for Alaska? Because for me, again, going back to looking at the rural areas, I mean, some of the people that are that may need that contact tracing, maybe living miles and miles away from you, and they could take that one healthcare worker like significantly away for a good portion of a day or a couple of days just to do some of that work. So what do you think is some of the leading causes of that shortfall in the healthcare workers or nurses for that perspective?
I don't know, Val, did you want to go first?
Sure. So let me first introduce myself properly. Puing ano kakalu ka mitla makanan liu yupiu takita kami ana ka kuigino kami ataka kasa Port Orchard, Washington na kami my Yupik names are Nukakala kana mitla makanan, and my English name is Valerie Davidson, and I'm from Bethel. My mother's family is from Guiginok on the coast, and the name literally means village with no river, even though it's located on the ocean, because our families use the river year-round to be able to move from one community to another, because there are almost no roads in an area about the size of the state of Oregon, and 58 federally recognized tribes in that region that only has one hospital and one public health center, public health center that the state operates. So a couple of things are, one is that, there's a nursing shortage everywhere and has been for some time. And so really a part of that is, people have a choice about where they want to live and where they want to work. And while we're thrilled that Evie and Lauren are toughies and know how to live in Alaska and where Alaska is our home, not everyone has that same sense of adventure, right? And so, for example, in our villages and the region that I'm from, their average village size in Alaska is about 300 to 350 people. And so Bethel is like the New York City of the region because it has 6,000 people. It's huge by our standards. And we still have communities in many of our villages. 25% of our homes in Alaska still don't have running water. And so literally use a honey bucket. And so when the public health nurses travel to those rural communities, to the villages, they may be staying in communities that day that literally have no running water. And not everyone enjoys that sense of adventure. I think that's a challenge. The other part is that it's also been a challenge making sure that we can train people for these jobs, because quite frankly, we know that if we recruit somebody to come from what my mother still calls the United States of America, if we're lucky, they'll fall in love with Alaska. They'll be that typical Alaskan who's now, they came for 2 years and they were just going to see how it goes. And 30 years later, they're still here. But not everyone's like that. And so what we're trying to do is to make sure that we can train local people to be able to get the training here in Alaska and get them to continue to live here. For example, I work at the Alaska Native Tribal Health Consortium, and we're a statewide tribal health organization, and we serve all 229 federally recognized tribes in Alaska. And we provide comprehensive medical services at the Alaska Native Medical Center here in Anchorage. We do that jointly with South Central Foundation. ANTHC also operates wellness programs. We do disease research and prevention. We do rural provider training and rural water and sanitation systems construction and management. And we also enjoy a strategic affiliation with the Alaska Pacific University, which is our neighbor right down the road. And one of the reasons we do that is because we recognize that we need a partner who is agile and can meet our workforce needs now and into the future. So APU, Alaska Pacific University, has had a 4-year BSN program. And now we just started last year in the fall, a 2-year associate degree in nursing. And then this fall, I think we're starting a program for licensed practical nursing in Bethel, in collaboration with the Yukon Kuskokwim Health Corporation and Utlead Nagabat. So a part of it is, it's somebody told me once at a conference, they said, well, you don't have a nursing shortage. There are plenty of nurses. They're just not working for you. And so, but I don't know that I always agree with that, but I, certain places in the country have competitive advantages, and Alaska has done a really, I think, remarkable job of appealing to people who love a sense of adventure and those kinds of things. But I think it can be challenging at times. I think from the state's perspective, and I don't want to speak for the state, I'll let Lauren step in here, but our state budget has not been stable for some time, and being able to hire people and have them expect to be able to keep their jobs and have that job security has been, I think, challenging at best. So
Right.
Lauren, did you want to jump in?
Gee, that's so well said, Val. Thanks. Yeah, just building on your comment about nursing shortage, that's common for us in Alaska, but also nationwide. Also, thanks to the De Beaumont Foundation, we know what that looks like nationwide public health workforce too. So, have been struggling to keep public health positions filled with folks that are ready to go and meet minimum requirements for that kind of work nationwide, but that's true for Alaska as well. And, from a PHN perspective, and I think I know she appreciates this one, when thinking about what does it take to get someone in a public health nursing position and to keep them in that position, it's really complex. And it really hinges on this one thing, is that we're into population focused healthcare as a public health nurse in Alaska. So, as I mentioned earlier in the show, we've been around for 128 years. And most of that time we were focused on individual client-based care. So we've been on snow machines and still are, ships, dog sleds, you name it, to provide individual client-based care. But around 2000, to hear the first talk about, hey, PHN's in Division of Public Health, you folks shouldn't be duplicating services or competing for services. So we, as a section of public health nursing, made the official shift to population-focused healthcare in about 2009 or 2010. And so what does a public health nurse do? We really apply services at 3 different levels. And those 3 different levels are systems change work, community level interventions, and also some individual client-based care. So now getting back to thinking about hiring folks and retaining them, all of us grew up professionally in systems that are based on individuals and perhaps families. But there are very few educational systems that prepare us for public health or population-focused positions. So there might be nurses out there, but we know there's a shortage. But it's even tougher when thinking about even to get someone who can meet the minimum requirements for what's really a different kind of job. So we're looking for folks that are really strategic thinkers and focused on primarily of the population. And so we also have like what we call an ecological approach. And what that simply means to us is that we recognize that there's a lot of different determinants to the health of a population. And so we're looking at the aggregate data or those kinds of markers that maybe can be shifted in a culturally appropriate way to improve the health of a population. A real good challenge. It's probably one of the things that keeps me in the position. It's a it's a good challenge to be sure.
Yeah. Now, as you're talking, like in my head, I'm thinking of different ways because when I think about Alaska, again, I have, other than my own cruise about 12 years, 11 or 12 years ago. When I think about Alaska, and I have a really good friend that actually moved to Alaska many years ago, and she loves it. And she specifically loves it because of, really, she's very outdoorsy. Like, she loves the outdoor life. And Lauren, just from your own Instagram site of you skiing home or something like that, I think I saw a while back. So it is a different style of living. And I think there is a population of nurses that would really be interested. And there's even a population, because we have we have nurses that go into the Peace Corps. We have nurses that go and do travel nursing specifically because they want that change of environment. There is, and as you're saying, from a public health perspective, I wonder if there's a opportunity to develop like a residency program for nurses, because it sounds like in my past, back in my military life, I went through cold weather medicine training. So I mean, I can build a shelter and survive in the snow for about 2 weeks. That's all I've tested myself for. But it sounds like there might be an opportunity for, whether the state or some maybe philanthropic organization to develop a residency program where there's a transition, even some new grads, perhaps from other states that would be looking for new grad positions into public health. Because I know some of my students, and especially some of my second career students that have left another position and have gone through an accelerated program, really are looking for rural health, and they're not looking to move into the big cities, even though they're going to school in the big cities. So I wonder if there's an opportunity for something like that, if there's funding, or a grant or a pilot study. I think that would be fantastic, to teach them how to actually do some of those things, like, hey, what do you do when you go into a community without running water, right? Because I think there is a sense of adventure, especially maybe among some younger individuals that aren't tied down by anything other than they're looking to get into the profession. Because in my head, I'm like, I want to do that, except I have a wife and kids and family, and I'm sort of not stuck, but I'm geographically, I can't necessarily move. But I think it has a little tingling sensation for me when people say, hey, there's an adventurous side, because I'm not very good with four walls type of organizations, even though I have been. So I think there's a lot of opportunity. And now, and so the question, I guess, I'm trying to put together in my head is, what is the state or any other organization within the state doing to recruit the nursing or the healthcare workers that it needs, other than what was mentioned with the partnership with the university that's already there. But from, because like I said, there are pockets within the US we have like too many nurses and we don't know what to do with them, especially from a new grad position. I can tell you, like in Los Angeles, we have issues with getting especially the new grads hired on, just because there's so many people just come here because it's the big city. But again, some of the people that are studying here are looking to go elsewhere. So what is the state or any other organization doing to recruit?
Maybe I'll start, and I know Evie's got a lot to add too. But
Yeah,
what, a wise guy once told me the only way to get experience is to get experience. And the reason that I mention that is, in a world of population-focused healthcare, we very much understand that most people don't have a history of population-focused healthcare. So what we have internally is actually positions, excuse me, positions that go hand in hand with a training program to get folks up to where we want them to perform at an expert level. And so specifically, what I'm talking about is that we have an entry-level public health nurse 1 position, and it's flexibly staffed to a public health nurse 2, and then a 3 like myself. And Evie here, one of the many reasons I like working with Evie, and it's a long list, besides her very good sense of humor, is Evie's actually been with the state for about 6 months longer than I have, and I've been with the state for about 8 years and about 8.5 years almost. So what that means in our system is Evie has trained a lot of brand new public health nurses and brought them through our comprehensive orientation program. I don't know, Evie, if you wanted to comment or share what that kind of looks like and feels like in Bethel.
So I can just tell you how I started. I graduated from the nursing program here, and it was an ADN program. And then I wanted to get my skills all set before I came to public health. I've always wanted to come to public health, and that was one of the reasons why I came here. And one of the previous managers that was here, she would call me like every week or something, or send me an email and bug me to come over here. But I think it's because I was from here, and she knew that I knew a lot of people here. I grew up in this area, and I would definitely stay here. And I think it really helps that we have this ADN program here. And a lot of the girls that graduate, or girls and boys that graduate from the program here, they tend to go to YKHC to get more experience, and then our skills, their nursing skills up to speed, I guess. And then they start looking elsewhere, and I think this is where they come, public health. And just to let you know, my daughter graduated as well from the nursing program here, and now she's the charge nurse at YK. I was trying to recruit her, but she wants to stay over there.
So yeah, but it sounds like, I mean, from my perspective, as I'm thinking about this, I don't think enough people know about you. I think, I I'd like to think I kind of know what's going on everywhere, even Hawaii, just because I have friends that work in that system. I don't think enough people know about opportunities in Alaska and what Alaska has to offer. And you guys need some like Alaska commercials with a nursing twist on it for the adventurer RNs out there. Hopefully this podcast will get you guys a few nurses. I think that'd be fantastic. Now I want to kind of switch gears a little bit, because I know we mentioned Alaska. Just there's so many different populations in Alaska. And there's a whole cultural component, and especially with the Alaskan Native population. How is public health what does the healthcare system look like, especially when we talk about the various cultures that exist within the state? And I know, Val, maybe you can start this off, because you are you're working in that arena right now.
Sure. So a couple of things. One is, so I used to work at the state. I worked at the state for 4 years, and I've worked in tribal health for 16 years. And what I've seen over and over and over again is that when tribes, when the state and the federal government work together, we have much better outcomes. And we've seen that every day, and we certainly have seen that during the pandemic with regard to testing, vaccine allocations, deployment, messaging, etc., has made all of the difference. And, it just constantly reinforces my belief that people really will do the most amazing things under the most impossible of conditions, as long as we have the right reasons. And children and families and communities are always the right reasons. And the great thing about Alaska is that it's still a place where, if your snow machine breaks down or your boat breaks down, people stop and ask to see if you need help, and they'll do whatever it takes to make sure that you make it. And that wonderful Alaska spirit applies to this work that we do too. And so just to give you a sense, I'm going to introduce you to the tribal health system a little bit. Just to give you a sense, in Alaska, all care that used to be provided by the federal government through the Indian Health Service is now provided through collectively the Alaska Tribal Health System. And the Alaska Tribal Health System really is a affiliation of 25 different co-signers who each negotiate a common compact with the Secretary of the U.S. Department of Health and Human Services. And collectively, so each organization really is geographically distinct, and each organization is autonomous. And there are 25. And they may be an individual tribe, or they may be a larger tribal organization, like Evie was mentioning, the Yukon-Kuskokwim Health Corporation, YKHC, provides services on behalf and under the authority of 58 federally recognized tribes. And serves a region approximately the size of the state of Oregon, with no roads connecting any communities and one hospital in that entire region. But collectively, so there are 24 additional co-signers to the compact. Collectively, the tribal health system has about 12,000 employees wide. And just to put that in perspective, the Alaska Department of Health and Social Services, where I used to work, has about 3,500 employees. So on a scale, the tribal health system is larger, but the services are much more. They're much more than just public health. But we have the same interests, we have the same priorities. We're focused on population health, we're focused on wellness and prevention, huge focus on immunizations, et cetera. And there are times in our past, and also recently, where as that state budget fluctuated up or down, the tribal health system and the state public health system really flex back and forth to make sure that individuals in a community basically are continue to be able to receive care. But we do definitely have some unique challenges in Alaska. Despite all of this great work that happened in this incredible collaborations, Alaska Native people here in Alaska really were disproportionately impacted by the pandemic. We were more likely to get sick, we're more likely to die. Our mortality rate was 4 times that of the white population in Alaska. Wow. And a large part of that is simply because of the lack of access to clean water and sanitation facilities. And we still have 32 communities in our state that don't have running water. Another 17 communities where only some of the homes in the community are connected to a reliable water source. And so really, Alaska couldn't do it without the tribes playing a role, without the state playing a role, and without the federal government playing a role. And the wonderful thing about Alaska is that while we are geographically large, our population is relatively small, so we know each other. And if something's not happening in one part of the state, oh my gosh, there's something happening here, there's an outbreak there, people rally really, really quickly to come together to make sure that people have those resources. And we have a saying that, when you grow up in a village, it doesn't matter whether it's 40 below or 40 above, you still have to get up in the morning, you pack your water, you chop your wood, and you do whatever it takes to be able to help yourselves and help each other to make it through the winter. And it's that same mentality of, people check in with each other all the time. Are you guys doing okay? This is what we're starting to see in our region, in our community. This is what we're seeing in our facility. What are you seeing in yours? And you tell one person in one community on one teleconference, sometimes it felt like during the pandemic, it was around the state in less than 15 minutes, which is a really good thing.
Oh, that's amazing. Now, when you talk about, and I never thought, in my, again, it's really from my own ignorance. But when we talk about no running water in so many different communities, in my head, it's always been, again, like what's on TV of, oh, look, this one person, like those reality shows where they go and they build out in the middle of the woods, and I'm like, it's like, okay, they don't have running water, but to think of actual communities of people not having running water in the US now, it's sort of mind-boggling for me. A lot of things are mind-boggling. The fact that we have homelessness anywhere in the US is mind-boggling, and we have hungry children is mind-boggling. But now, is this the fact that there's no running water? Is this I don't want to even call it is this by choice, but what are the challenges in getting running water to those communities from an infrastructure perspective?
Well, I'll tell you that no one chooses to not have running water.
Right, exactly.
So one of the challenges is just the cost of being able to build that infrastructure in rural communities, and just transportation. You
Right.
can't drive to any of those communities. So you have one chance, and that's to get it on the first barge of the year that goes around the Aleutian chain from Seattle or, Anchorage, around the Aleutian chain and up the river, around the ocean, upriver to your home community.
Right.
And, just to give you a sense of the cost of things, of that transportation adds, like a gallon of milk, I think is $9. And that's if you're lucky in a community, a hub community, a big community like Bethel, where you actually can get fresh milk. The rest of it is powdered and canned in most communities. So, So there are a couple of things that are out there that one is the federal rules that decide, well, we can't fund this sanitation facilities project in this community because it costs too much. It's not economically feasible. And I hope that folks understand that when people say things like that, what they're saying is that what they're really saying without saying the words is that we're not worth it.
Right.
Our lives don't matter. And if you look at the health impact, I mean, constantly during the pandemic, we heard over and over again, wash your hands, constantly. And imagine being a parent with little kids and knowing that you couldn't do the one thing that would most likely keep your family safe. And we ANTHC and the CDC did a study a number of years ago about the impacts on health of infants in communities without adequate sanitation facilities, and found that infants in communities without adequate sanitation facilities are 11 times more likely to be hospitalized for respiratory infections and 5 times more likely to be hospitalized for skin infections. And it's easy to get lost in those numbers, but effectively, what that meant is that 1 out of every 3 babies in a community without running water can expect to be hospitalized. But again, these communities don't have hospitals and we don't have roads. So every time that happens, that baby needs to be medevaced out of that community. If you're lucky and you got a cheap medevac, it's about $50,000.
Wow.
But typically $100,000, $125,000, up to $500,000 for that one medevac to be able to address that need. And so when we talk about population health issues and keeping people safe, it is way more than just what you would expect to see in other places.
Yeah, and yeah, as you're saying this, I'm like all the things we take for granted living in big cities are just the fact that my Amazon delivery is a day late. I get kind of peeved, but but thinking about some of these communities, and you're right, it is. Actually, I had this conversation with a friend of mine the other day of the value that we place on human beings, and when things like this, as you're mentioning, like, oh, it's not economically feasible. It really has nothing to do with the economic feasibility, but it's more of a, and it's not even having a privilege or something like that, but it's sort of like it's humanity, taking care of humanity, taking care of each other, something like running water or anything like that. That should be just a given that everybody has access, but unfortunately, it doesn't. It's mind-boggling. Thank you for sharing this, because yeah, it's things that we don't normally think about. But there's a population of individuals that are actually living through this day in and day out. Um, Now, from a COVID perspective, and you mentioned, things like even running water not being available for so many communities. From a vaccination perspective, I just briefly looked at numbers and I saw uh, the uh, um, uh, the native communities are doing better with vaccinations than the rest of Alaska. What are the challenges and what's worked and what hasn't worked trying to get vaccinations out to decrease the impact on the population? And maybe we'll start with Evie and work our way around.
So what worked well is that when in the villages there's with the vaccinations, I feel like there's a good system with the tribal entities and between them and the hospital here. There's like a good system going there that where they have people sign up, and then as the list goes on, when there's enough people, and they send out like vaccine people who are going to vaccinate the village. But the charter is expensive, so they have to wait until there's like enough people to send these the vaccinations out to the villages. But all the health aides in the villages have been trained on giving the different vaccines, the Pfizer and the Moderna. And there's like a time limit between those vaccinations, so that you have to go out there quickly or the vaccines will be wasted. And those were some of the challenges in some villages where the weather got bad and we couldn't go out. So, but other than that, we definitely use the vaccines here in Bethel if the planes didn't go out.
Yeah. Now, have you guys moved on the Johnson and Johnson also, or has that worked better if you have used that?
So yeah, Johnson and Johnson has been used, but I think there was a hold for a little bit, and then I think they're using it now. I'm
Right.
not sure where they are. I feel like YKHC has been using more of the Moderna vaccine in the villages because it's so much of that, the time limit that you have to use the vaccine, that is the one that has been more effective to use in the villages.
Yeah. Just from a timing perspective, and the fact that you have to keep the Moderna and the Pfizer one so cold, and there's a time limit. The Johnson and Johnson just seems to be the more practical, perhaps, vaccine for some of these villages. Lauren, how about from your perspective on the vaccinations?
Oh, Val, go ahead. You're ready to chime in.
Oh, yeah, go ahead, please.
So I would say a couple of things. I mean, not only so the thing that made such a difference in Alaska, really both in testing supplies but also in vaccinations, is this partnership between, again, the state, the tribal health system, and also the federal government, mostly between the tribal health system and the state. And there was a task force that met every single week and sometimes every single day. And one of the things that made a difference was the commitment to, it was equity, not equality, that mattered in the distribution of supplies. And so, making sure that this, based on population, the number of people, that wasn't necessarily going to cut it. And that there were communities that were especially vulnerable, communities where it was harder to get to, communities that were isolated, communities that have already disparate health status. It was a lot more, it was important to get to those communities quickly. And really, it was also about, coordination and communication across Alaska. And I will say that relationships across Alaska, as I said before, are well known. People have known each other for years, and we maximize those relationships at every single opportunity. And looking at, are there disproportionate potential impacts on a particular population? And if that was yes, then okay, then what can we do to make sure that we get them additional supplies, and what's happening? And the other piece is, it's also like, for example, we made priorities for vaccinations for things like, if a community had some of their last language learners or their language speakers or culture bearers, they were among some of the first people to get vaccinated, because losing one person in that community meant a language that had existed since time immemorial may be gone. And so really it was about making sure that that we stayed in constant communication, so that we knew, okay, there's bad weather in Guiginlook, and that means the vaccine is sitting at the airport, and it's going to go bad if we don't get it out in the next however many hours. Then swap that out, redeploy that to another facility in Bethel or to another community to make sure that can still be utilized.
Yeah,
But Lauren, did you have any others to add? Sorry.
I, that's very well said, both of you. I guess the only things that I would add is we've kind of had a historical context that's led us to a place where we can enjoy these partnerships and community, family, and individual outcomes. What I mean specifically is, the state's constitution, became effective in 1959, outlines that it's the state's responsibility. The health of the public is the state's responsibility. But as Val is outlining there, we couldn't do that without our existing partnerships. And then kind of fast forwarding a little bit further, closer to the future, thinking about how in 2001, 9/11, that really set the stage for us to advance emergency preparedness to strategic priorities. So what's that mean? It means in our world of public health nursing, we really started to train public health nursing in regards to emergency preparedness. So things like a point of dispensing, we really got started on that kind of work, that kind of planning around 2008 or even before. And then in 2009, of course, H1N1, as a state, certainly as a nation, we were able to carry forward a lot of lessons learned. And I think Valerie said it best there. Having access to vaccine is one thing, but really focusing on health equity, or those initial stages when there were only 50 doses. As a team, we really answered the question: who needs it first in order to preserve and protect our communities? Yeah, I think those are the biggies for me.
Yeah, it sounds very. Yeah, please
Can
go
I
ahead.
add, I'm sorry, can I add one more thing? I was recently on this other discussion where people were talking about, who are the trusted messengers? And somebody came on and said, we need to stop using that term because it feels so transactional. What we're talking about is relationships and a long-term relationship so that, if somebody calls and says, hey, I need help, it's not transactional. It's that relationship. And so it's things like, I mean, I'm on this call today or this podcast today because Lauren sent me something on Facebook Messenger and we have that relationship and I know him and I trust him. But it's not transactional. It's that long-term relationship. And that's where, and that's the benefit of that's so if you're a person who's interested in in working in Alaska and being a part of something like that where the people you work with become family and you have an opportunity to make incredible improvements in the health of individuals and families and communities and a whole population, and you have a sense of adventure, come on over to Alaska. We need you.
That's beautifully said. I wish we could end the podcast on that because I think that should be its own. That's your commercial right there. That's your commercial right there. Has there been any vaccine hesitancy? Because I know it's just from a logistics perspective. For me, it's mind blowing of the hoops you guys are jumping through to make sure the communities are getting the vaccines and everybody there's equity in the distribution, and you're taking it to a whole another level from a preservation of cultural history in some of that distribution. So has there been any hesitancy or challenges from that perspective from a community or individuals of why they are not being vaccinated? Because I know like it happens everywhere else in the US, just from a Alaska perspective.
I think every community is different. And so we always say, if you know one tribe in Alaska, you know one tribe in Alaska, because I mean, Alaska is so big. We used to have 4 time zones. I mean, literally 4 time zones in Alaska. So I would say that generally what we've seen is we have much higher vaccination rates in communities that are smaller, in our tribal communities. And that's pretty simple. The health aide knows everyone, knows every baby born in that community, and they know where to find us.
Right.
In some of our larger population centers like Anchorage or even beyond Anchorage, the Valley, people have some really interesting views about vaccinations, which I think are really unfortunate. And, sometimes, having all that information out on social media, I think sometimes some of that information isn't necessarily accurate. And so, but I read it online. And so a lot of that effort has been lately about really making sure that we talk to the community doers in a community. Who are the people who it's not necessarily their job to do this, but that person in a meeting where when somebody speaks, everybody stops and listens. That's the community doer who has that credibility, who says vaccinations are important, is really how we reach people. It's really about relationships.
Yeah, I was about to say, it sounds like it goes back to that same relationship concept that you mentioned before, and it's true. And I think we need to be building definitely more of those relationships everywhere, not just. But it makes sense. So I appreciate this. This has been incredible, and I appreciate all of the knowledge you guys have shared. Anything else you would like to share before we wrap this episode up? We'll start with Evie.
I don't have anything to add.
Right, well, thank you again, Evie. I appreciate what you've shared. Lauren?
I guess when thinking about pandemic response and the PHN's role, one thing that's a little bit harder to see or uncover are these core competencies of public health nursing practice and scope and standards of practice. And so these are the kinds of things that govern or guide how it is that we go about our job, in our presence in a community. And these are kind of what I kind of think of one of the successes of our contribution in the pandemic. An example might be, we never enter into a village without an invite. And so kind of what that means to me and us is a culturally appropriate approach to population-focused healthcare. And that plugs into building relationships and maybe even rebuilding potentially tentative relationships, because at the end of the day, and that's kind of what counts, and that's what's going to move us forward.
Great. Thank you so much. And Val?
So one thing I would add is that, there was a lot more flexibility during the pandemic, from public health agencies and just a whole host of folks. And, I think what that showed us is, what is possible when some of that flexibility exists. And my philosophy is, if it worked well during a pandemic, maybe some of those things we ought to apply every day. And those flexibilities really show us that when it's important, we can do those things. And so what are those barriers that exist when it's not a public health crisis that we should implement every day that will allow us to be able to continue working together more effectively? Because I'm going to keep working with Lauren and Evie, because we know each other, but everyone in this country should have that opportunity. And the last thing, one more time, if you're a nurse, come on over to Alaska. We would love to see you here. We promise you an adventure and lots of excitement and an opportunity to make a real difference. Brianna, thank you.
Thank you so much. Again, I appreciate you, all of you, sharing your time and your knowledge and your wisdom. I'm better for it. I always tell my colleagues, I'm like, I only speak to people I want to speak to. So it's my podcast. I get to speak to who I want to speak, and I'm always better off for the people I speak to. So thank you so much. I greatly appreciate your time. You have been listening to the RN Mentor podcast. This has been a special episode of season 4, and I look forward to bringing more guests to you as we kick off this season. Thank you so much. You've been listening to the RN Mentor with your host, Ali Tayeb. Please don't forget to visit www.alirtayeb.com. That's www.alirtayeb.com for podcast notes and resources. And don't forget to subscribe. Until next time, I wish you fair winds and following seas.